Hello and welcome to today's Hipaa Chat. I'm Carol Flag of Answers Media Network. Thanks for joining us today. If you're new to Hipaa Chat, sit back, relax. This is very much a live Q&A kind of format with our guest host and myself, taking questions from the registration list and taking questions from you, our audience. Hipaa Chat would not be possible without eFax Corporate. They are our sponsor and a brand of J2 Cloud Services. They've been, as of December 31st, 2017, achieved 22 consecutive fiscal years of revenue growth. For more information about eFax Corporate and their products for securely transmitting ePHI, visit enterprise.efax.com. Of course, he's not really our guest host. He's been with us way too long for that. I think he's our host. Is David Harlow. David is a healthcare attorney. He is an award-winning blogger. His legal practices does focus in on this area of data security and HIPAA breaches laws. He works with providers, large health organizations, payers, vendors, and anybody in the healthcare space related to HIPAA and the laws around HIPAA. He is also host of Harlow and Healthcare on our own Healthcare Now radio station. You can learn more about him by reading his award-winning blog, Health at blawg.com. You can contact him at david@harlowgroup.net and listen to his podcasts of his radio show on the healthcarenowradio.com website by visiting his program page. You can also learn more about Hipaa Chat and view past events on our YouTube channel and LinkedIn. You can listen to podcasts on our SoundCloud channel. If you go to soundcloud.com and search for Healthcare Now Radio, we will pop up. And of course, please follow us on LinkedIn. We have a Hipaa Chat group as well where you can pose questions and discussions. So David, we were at HIMSS about a week and a half ago, and a lot to talk about today. Obviously, we're going to leave plenty of room for questions, but these are our three topics today, and we might as well sort of dive right in and just give them maybe a higher overview of what we're talking about today, and then we will get into the Q&A.
Sure. So nice to speak with you again.
Yeah.
And HIMSS, of course, was HIMSS, a crazy experience, and a
Your
delightful
first time.
experience at the same time. Yes, believe it or not, my first visit to HIMSS,
Yeah.
and it was remarkable. Tens of thousands of people there, and a tremendous amount of talk about new technology, about innovation, about ideas of what to do with all this health data that we're dealing with and how to use it to make healthcare better.
Yes.
In the months leading up to HIMSS, at the turn of the year, really, December and January, there was a lot of talk about texting patients, right? This is an issue that comes up again and again, texting patient information. And the Joint Commission had issued policies on this a number of years ago. CMS had gotten into the picture, and there was some communication, emails that had gone out from CMS to two different hospitals a number of months ago now, basically saying that text messaging, including secure messaging services, would be entirely forbidden. And when those emails got out, when the story got out, everybody sort of went crazy because, in fact, there are a lot of text messaging services that are compliant with HIPAA, and there are approaches even beyond the quote-unquote secure text messaging services that may be compliant with HIPAA if implemented appropriately. So there's what then happened is that we got an official statement from CMS that was more in line with the prior policy, right? So there is a policy document out there from last December on texting patient information among healthcare providers. And that's available online at the CMS website. We can make a link available as well. There's a couple of problems. If we look at this from sort of the Medicare conditions of participation perspective, medical records need to be retained for 5 years under the conditions of participation for Medicare. And medical records are supposed to be accurate, accessible, authenticated, secure. And question is, can a text message be a part of that record? Records are supposed to be kept confidential. Is a free text message, in fact, confidential? And the key issue, I think, from the CMS perspective is orders are to be entered into a medical record either by hand or via CPOE, right? So texting is not permitted, but CPOE, computerized provider order entry, is permitted because it's set up to auto-download into an EHR with date, time, and authentication already addressed, right? So that's sort of the framework that CMS is working with. And they recognize, as we all do, that texting is a valuable means of communication, but we need to sort of work within this framework of privacy and security that we have. Providers can text between each other as long as it's secure, but orders need to be entered into the EHR via a CPOE tool, not just sort of a freestanding text communication tool.
All right, I'm making notes
Sort
here.
of that's sort of the framework that we have. So, I mean, that's all well and good, but then of course the question is sort of how does this work in the real world? And I'm sure we'll have some questions on that front. But another thing to keep in mind generically is that to a certain extent, if a patient consents to being texted, then you can text that patient, right? Text messaging is not just about communicating between and among providers, it's about communicating with patients. Now, most of us have smartphones these days, but there's still a small minority of folks who have what we call feature phones, right? The flip phone or a candy bar phone, not a smartphone, where you want to be able to communicate via text message. So most of us are using apps of one sort or another to communicate with our healthcare providers. But there's a minority of folks who are out there using traditional text messaging. And again, you can create an environment within which that can work, but it takes some work to put it all together.
And I just was making some notes here because we did get quite a few questions related to this topic today. And I think when we get into the Q&A portion, we'll do a quick review on some of the things you just said so people have a little bit more guidance on that. Obviously, it wouldn't be Hipaa Chat if we weren't talking about some sort of breach or settlement, or unfortunately, right? In this industry.
Unfortunately, someday, maybe someday.
Maybe someday, but that day is not today,
Right,
obviously, since we're going to be talking about a $3.5 million settlement.
Yes, well, as my old car mechanic used to say, hope burns eternal.
Oh.
So we can maybe but meanwhile, we are dealing with some significant breaches, significant fines. The Fresenius, this is one of the national dialysis service companies. Fresenius was fined $3.5 million, or rather, there was a settlement with a $3.5 million payment and a compliance agreement entered into by the company based on a number of breaches that really were from years ago, several years ago. The facts of the case really go back to a number of different incidents in early 2012. And Fresenius self-disclosed all of these 5 subsidiary entities problems in various places around the country, a number of different states, and the investigation by OCR found that each of these covered entities had a breach, impermissibly disclosed PHI for a purpose not authorized by the privacy rule. There are individual findings with respect to each of the clinics that had to do with inadequate policies and procedures around dealing with security incidents, around dealing with hardware and electronic media that contain PHI, other issues that really weren't addressed appropriately that allowed for tampering with BPHI and theft, encryption and decryption wasn't handled appropriately by one of these locations. So what the regulators found here is that this was a pattern at the parent company level, right? So 5 individual sets of breaches might not necessarily add up to a $3.5 million penalty or settlement. But I think one of the things that goes into this calculus is how do we get the attention of a giant company like Fresenius? And how do we get Fresenius to change the way it acts prospectively in order to secure data more appropriately? So that sort of feeds into the size of the fine.
And it was sizable, and we're going to talk about this obviously in the Q&A as well, related to, you know, what that means as far as security incident reports and security risk analysis and all that. So keep those questions coming in that regard. And then finally, we're just going to touch real quick before we get to the Q&A about blockchain. That was obviously at HIMSS, David, as you know, but one of those what I would call trending topic. And you know, there you know, some interesting dialogues around blockchain. You know, proponents of blockchain saying it's literally unhackable. Yeah, I'm not really sure if that's true or whether some of that's hyperbole or what. But I think that as blockchain as a topic begins to develop, certainly we'll have to be watching it for a future Hipaa chat, and we are going to talk about it a little bit on our cybersecurity panel discussion next month. But what are your thoughts about blockchain and cybersecurity, and what some of the things that you heard at HIMSS?
Well, it's certainly an issue that we need to deal with. I mean, it's an issue. I mean, it's a solution or a potential solution to a whole series of issues that we have about authenticating information, about securing information, about ensuring that information is available only to folks we want to make it available to. So when we say using blockchain technology, it's not like we're going to put all of our health data on a publicly available ledger, right? Which is what some of blockchain is about. But using the blockchain technology, create a framework for authenticating individual pieces of information, right? So we don't need to get into the technology of blockchain that deeply, but from my perspective, in terms of the implementations that are out there or in development, I feel that we're still not quite ready for prime time. Now, there are a number of different uses for blockchain in healthcare. I mean, there's generically the desire to have another sort of solution that helps with cybersecurity. There are ways in which we can improve collaboration among providers or among researchers and in looking at population health issues, even looking at drug supply chain improvements, perhaps by using blockchain to authenticate particular batches of drugs. So we're not dealing with counterfeit pharmaceuticals. but more in the wheelhouse of what we talk about on this broadcast is the area of healthcare finance, claims adjudication and billing management, and also clinical health data exchange and interoperability. Now, there's certainly some implementations dealing with health data exchange and interoperability. I mean, people talk about Estonia, for
Yeah.
example, as the country of the future, using blockchain in a variety of different ways. It is easier, certainly, to implement a new technology in a country like that, which has a much smaller population than our country, of course, and has other features that are different from our national government and national or lack of a national healthcare system. So there are differences. Are there opportunities to use blockchain to improve data security? Yes, undoubtedly. I'm not convinced, though, that we're quite at a working model stage or an implementation stage in the US.
I, I thought it was interesting, just sort of a final thought about this is that there were people at HIMSS. I suppose the naysayers are saying, well, blockchain, this is what Bitcoin uses. I mean, it's not Bitcoin, but Bitcoin uses blockchain technology for their virtual currency is the issue. But it was funny how people just sort of that leap of that leap there. Well, if this is what Bitcoin does, then I don't want to talk about it.
Right. The underlying technology may be helpful. There's also in healthcare and healthcare technology, there's a lot of talk recently about initial coin offerings, which may seem to be to some fraudulent or an end run around the Security and Exchange Commission in terms of investment regulation. So there's a million different kinds of coins that are out there. So it's not just about the particular coin, but a question of how can we use the underlying blockchain technology if it can be used to undergird a secure currency exchange. It could be used to undergird a secure exchange of health data as well.
Right. All right, so on that note, we're going to move into the Q&A here. Just remind people, please check out Dave's award-winning blog, healthblog.com. You can follow him on Twitter at healthblog. Check out his Harlow on Healthcare radio show that runs on our radio station, Healthcare on Our Radio, and on the program page on our website. So let's first talk about getting back to the first item that we discussed, which is texting patients and CMS's statement on that. We had several people who registered, and actually several people now in the live Q&A asking for guidance for dealing with patients. So, it's okay to text patients. We need their approval. What would be the standard for getting that approval? And what sort of things can we text them? Sort of, I just rolled in about 4 questions into 1.2 questions for you.
Yeah. So, I mean, part of the issue is, who's texting whom and with what, right? So the CMS guidance is really about provider-to-provider texting of clinical orders, right? So they're pretty clear in saying you need to use a CPOE system to do that. And it kind of makes sense because you want to have a central repository of those orders that are actually incorporated into the electronic health record, documenting the care for a particular patient. A separate issue is the question of communication between patient and provider, right? Now, some providers are interested in making those communication barriers as low as possible so that patients can in fact communicate with them easily and not by logging into some portal where you've forgotten the password because you only do it once in a while, and it becomes difficult, becomes a burden. I've spoken to some providers in the past who would say, yes, my institution wants me to use the portal for communication, but I would much rather use some other mechanism to communicate with my patients, because that way they'll actually communicate with me. And particularly in an age of value-based payment, where
Right.
provider organizations are at financial risk or have the opportunity for financial reward based on cost and quality of care, really, moving away from the fee-for-service model. So a clinician is not interested in just simply saying via phone or text, "Oh, come into the office," but rather is extremely interested in resolving an issue proactively via phone or text. This is a setting in which we really need to try to make it easier to use these tools in a compliant way in order to reach patients, in order to be able to help them manage care and manage their care and their health in a way that works, right? Instead of taking time off to come into the office for every interaction. So the issue here is that HIPAA protects patients, right? So the it is up to the patient, or it is within the rights of a patient to waive certain protections, right? So if a provider organization, if a patient management, care management tool provider wants to be using text messaging as one of the ways in which it reaches patients, then at the beginning of the relationship, there needs to be a clear communication about that and about those risks, and an acknowledgement by the patient, yes, I would rather that we communicate by text. I understand the risk. It's not quote unquote secure necessarily, but I'm willing to take that risk because I'd rather have the easy communication with my healthcare provider.
Getting sort of follow-up questions as far as emailing and texting, using a smartphone. Does this occur on a standard cellular network? One attendee said, is that the same network that teenagers use to gossip amongst each other? So, this question of, when you send a text to a patient over a standard line, is it as simple as that? And others are asking, is there software related to this to keep it secure?
Oh, there's a million and one secure
Millions.
texting
There's a lot
solutions,
of them
right?
out there. Right.
And those are useful, and I would encourage people to consider using them for inter-provider communications. There are plenty of those, and those can be robust solutions and easy to implement solutions so that providers can communicate with each other within a secure platform, but using the cell phone texting kind of approach. Make it easy, make it simple. If you give those tools to providers on your staff or in your network, then you make it more likely that they will communicate effectively with each other rather than either using free text, which they probably shouldn't be doing, or not communicating, which ends up being bad for patients, bad for care, and potentially bad for the bottom line of the organization. So, it's not a bad idea to avail yourself of one of these tools. And in terms of communicating with patients, you can provide a platform for that communication. But if it requires an additional sort of login, you're putting a barrier in place, and maybe the solution is to open yourself up to free texting with patients. Though over time, as I said earlier, many more people, a much higher proportion of the population at large is using smartphones. There are apps that you can use for communication with patients, not only free texting back and forth, but also care management platforms so the texting is in the context of managing an existing concern or a chronic condition. The live texting back and forth augments the perhaps programmed texting, nudges, feedback that the platform can provide to the patient. So that mix of programmed and live communication may be very effective in helping patients manage individual situations.
Yeah, question from the audience. If a patient consents to text messaging, does that mean a provider can text another provider about them via unsecured text message?
That is not a direct authorization unless it is specifically provided by the patient. And again, based on Medicare's perspective on all this, even if you had the patient consent, it implicates non-privacy issues. So that is a separate concern. A patient agreeing to certain type of communication doesn't do away with the concern about a provider satisfying a condition of participation.
Okay. Another question from the audience. Do you need a patient's consent to use their masked data for setting up training? This is not text related per se, but do you need a patient's consent to use their masked data for setting up training data sets for training the public to use new products?
So if we're talking about training data sets for that do not contain PHI, the short answer is that in most circumstances, if there is the appropriate sets of agreements in place, data can be used by a service provider or by a healthcare provider on a de-identified basis for the purposes described in the question. The issue becomes, is the de-identified data going to be robust enough to do the trick in terms of training something or someone? And if the answer is no, then you need explicit consent for use of PHI by the individual patient.
One last text question. I think we'll move on. How do you handle it when a patient emails or texts the physician asking for prescription or other medical advice?
So the initiation of a message by a patient in a non-secure mode is generally considered under the rules to be the consent by the patient to be responded to through that same mechanism, right? So if you text a doctor, you're sort of expecting and hoping and wanting the doctor to text you back. The question, though, for the provider is, am I convinced that the patient really understands the limitations of this platform, of this channel, from a privacy and security perspective? And to be on the safe side, a provider organization ought to have a specific opt-in approach to that rather than just replying to a text message, right? So if there is that opt-in, then yes, information can be texted back and forth between a provider and a patient. But I would prefer to see an explicit opt-in at the beginning. Now, the folks who run the portals in your organizations and others are likely to say, no, do it on the portal. And I understand that and I hear that. But that is more about institutional preference than patient protection. I mean, obviously it includes patient protection, but the patient has a right to have this other sort of communication if the risks are disclosed and the patient agrees and consents to use that channel.
All right, so we're gonna, I think, move on to the $3.5 million settlement. If you've got additional questions or comments about CMS and their statement about texting patients and what David has had to say, please reach out to him offline at his email. So, a couple questions related to the the settlement of 3.5 million, they had 5 locations. Are you recommending that a risk analysis be done for each of the locations? Each of the 5 locations should have done a separate risk analysis?
So this question comes up a lot. I've dealt with
Yeah.
this a lot, where we're dealing with multi-site provider organizations. And what I have seen in practice is that very few of these organizations were sort of, you know, it's like, what is it in mythology? Athena born from the head of Zeus, all at once, right? It doesn't really happen in real
Right.
life. The evolution of each particular location, it could have been owned by another company, by another health system in the past, and then there's this sort of patchwork approach to integrating their systems with the home office, et cetera, et cetera. So each location, more likely than not, is going to be a little bit different from every other location, or at least from some other locations. So what I usually would recommend is you need to create different buckets of locations. These could all have been sites of health system X that was acquired 3 years ago, and their systems are a little bit different than all of your other sites, right? Or it could be sites that came online during a certain time period when you were using a certain platform or system or something else that's going to be distinct from the way your standard operating procedures are implemented in other locations. So it would make sense to at least do the risk assessment on a sampled basis across each class of locations, if not every location. I think that's a defensible approach.
Mm-hmm. Okie dokie. I've got somebody sort of chatted in that obviously doing a risk analysis can be challenging for multiple satellite sites with Hipaa compliance officials. And do you have any practical advice or solutions for getting that done? But you said sites, even in the same company, can vary a little bit, or maybe even vary a lot.
Right. Is the question about having an enforcement agency coming in and doing those, or doing them and demonstrating them for the enforcement agency?
Doing them and demonstrating them for the enforcement agency.
Yeah. Well, again, I think that
Yeah.
if you're doing it in an enforcement situation, then you're dealing with a particular agreement and arrangement with the agency, whether it's federal agency or state agency that's enforcing something similar. And you're going to have to deal with them on a case-by-case basis. My earlier statement about doing a sampling of different kinds of sites is in the context of doing an annual risk assessment, right? So you do a risk assessment on an annual basis across your organization, and you also do a risk assessment. You could do that more frequently if you've made some change to your systems, right, where you need to review those and see how they're being implemented. If you replace your entire computer system in the middle of a year, you don't wait till next year to do another risk assessment. So in that context, I don't see a problem with doing a sampling. If you're in the context of responding to an enforcement action, you're going to have to do what you can negotiate with the enforcement agency, and that is more likely to be dealing with the locations where issues were identified, and then a negotiated approach to dealing with all of your other locations.
So along the threads of the enforcement agency, obviously doing risk an SRA once a year, and more often if there's an incident or a significant change. What is considered, in your opinion, what is considered a good faith effort from the eyes of the OCR so you don't get fined? We already talked about once a year, obviously, a minimum, right? SRA.
Right. Yeah. Yeah. Once a year and more frequently if things are changing or if there are issues. Um, the, uh, the, um, the, there's an old saying that the law is as long as the chancellor's foot, right? It's, it, uh, in our modern age, we say about, the Supreme Court used to say about pornography, I can't define it, but I know it when I see it.
Right, right.
Um, so we're dealt that hand. We have a set of standards under HIPAA that we need to comply with. But every case is different, every situation is different, every organization is different, and every situation where the enforcement agency comes knocking on your door is going to be different. And there's a human factor. I often talk about human factors in compliance, but there's a human factor in enforcement as well. And that's not necessarily predictable. You can extrapolate from past cases about what has been seen to be legitimate, but you can't necessarily rely on that being seen as legitimate or sufficient in any particular case going forward. So a good faith effort really needs to be a best effort. I think that's the short answer.
Right. So somebody asked a question, with recent departures of some of the key people in OCR, do you think there will be less investigation of HIPAA complaints?
Well, I think it is, in fact, likely to slow down on a number of fronts. Roger Severino, the current chief of the office, spoke at HIMSS, and in a setting like that, a government official is hard pressed to say anything significantly meaningful. But he did say, either then or in an interview just afterwards, that the office is moving away from audits. They're sort of taking the learnings of the audit program and taking those and using them in terms of trying to educate and inform the provider community going forward. Unfortunately, I think that his office, in addition to losing staff, is being stretched thin with some other unrelated duties, uh, thanks to the initiatives of the current administration. And I think for those reasons combined, there's likely to be less enforcement or longer term, um, longer delays in terms of enforcement. So here we're looking at a case, we're talking about a case today based on facts in early 2012.
Right, right.
I think it's going to get worse before it gets better.
Right. Where are the highest risks for HIPAA breaches? Where?
Well,
that
the risks are many.
talk
I'm not
about
sure
talk about you know it when you see it, right?
Yeah, right. So I think instead of thinking about what are the risks, I would turn that question around a little bit and say, what are the what's the quote unquote low hanging fruit in terms of changing practices that can improve your compliance profile, right?
Mm.
It is critical to do, as we were just saying, the regular risk assessment, but the risk assessment can only exist in the context of having an up-to-date set of policies and procedures that are tailored to your particular situation. It's not a one-size-fits-all situation always. And staff need to be trained on those policies and procedures as they affect their individual work, right? So I think it makes sense with an organization of any size to tailor the training for different job descriptions and to test people on their knowledge as part of the training, follow up to the training. So if you tailor the training, make sure that's pushed out appropriately. If you have policies and procedures that are in place that are going to deal adequately with privacy and security issues for your particular situation. I mean, easy for me to say that, but that's really the hard work that has to be done in order to address potential concerns. As this Fresenius case demonstrates, there isn't one particular area of concern. I mean, some of the issues had to do with, what happens when you get rid of old equipment. Some of this had to do with not implementing an appropriate approach to encryption and decryption of data. Very different issues, but they're all part of the
Right.
scheme that we have to deal with. I think a huge risk, and we keep coming back to this, is the human factor risk, right? It is easier to put the technological solutions into place, but for all of those solutions, it just takes one staff member clicking on a rogue link in an email that comes in, and everything falls apart, right? So there's the technical solutions that need to be put into place to minimize the likelihood of that email ever getting through, but there's also the training that has to happen to minimize the risk of anybody on your staff ever clicking on a link in such an email.
And those phishing emails, they, certainly the look and feel of them become more sophisticated every single day. They're really they're really mirroring exactly what a bank looks like, or a travel site or whatever. It's a difficult thing, and you're right. I think
Right.
that training issue is huge. It used to be you could look for spelling errors and it was pretty obvious, but it's gotten a lot more sophisticated and more dangerous, I think.
Yep.
Yeah. Somebody asked, does being compliant, and that is in quotation marks, help reduce the settlements and fines if breached?
Yes. Absolutely.
Always.
I've
I'm not sure what the quotation marks mean. Like, is it like,
right.
I'm wondering if they think, does the provider think maybe they think they're being compliant, but they're not? I suppose how I
Well,
read
look,
that.
if you the key to this is storytelling. You need to have a good story to tell. So
Yeah.
it's not a question of if you will have a breach. It's a question of when you will have a breach. When you have a breach, you need to have a very good story to tell. So you can say essentially, officer, I did everything right. My seatbelt was fastened. I was driving below the speed limit. I hadn't had a drink yet. I was in a crash.
Right.
It's not my fault. If you can document that, then you can survive a breach without a penalty.
So being compliant obviously probably always helps it, and it's always going to help your case, right? Right. All right.
Yeah, but it's not only just being compliant, it's being able to document that you did
Document their compliance.
everything that you were supposed to do,
Right.
that you had the training for your staff, that they took the tests, that they passed the tests, that you did background checks again and again and again, that you that you minimized the exposure of data to people on a need-to-know basis, et cetera, et cetera.
Right. What HIPAA breaches should an entity be concerned about with regards to an HIE?
So an HIE is going to be essentially a specialized kind of business associate to not one, but many healthcare providers, covered
Right.
entities, right? So the issue is that for an HIA to really work, it needs to be relatively easy to access and to use by a huge number of people in different organizations. And obviously, being that accessible creates a larger face, a larger surface that's available for hacking. So that's the concern. It's always a challenge of balancing the accessibility of data for proper use and the securing of data against improper access and use. So it's a challenge.
Right.
There's certainly HIEs in existence around the country that are doing this well, and that's it's a problem that has been, for the most part, managed.
Sort of back to the phishing and the ransomware previous question. One of the attendees chatted in, and this is true. Phishing caused the biggest PHI breach ever, and that was the Anthem event. But CEs and BAs just don't seem to get it. How can we help them understand the risk and that the HIPAA rules are a blueprint to minimize or defeat cybercrime?
Well, I keep saying it over and over again.
Yeah.
Everybody on this call can keep saying it over and over again. Hopefully the message gets out. The problem is that we continue to have breaches. We will continue to have breaches, and the issue is that we need to continue to promote the value of compliance, not just for compliance's sake. And as I said before,
Right.
you need to have a good story to tell, but it's not just because you want to have a good story to tell. It's because you want to, by living that story, you're going to prevent breaches. You're going to prevent disasters. And the ones that happen, we want the ones to happen to be only the ones that we couldn't have prevented no matter what we did.
Right. It's not just about OCR. It's reputational. It's all of that. So to protecting the patient's information. Speaking of breach notification, do most organizations do a breach notification after a ransomware incident?
Interesting question. So the government put out a guidance document on ransomware specifically. Is a ransomware attack a data breach under HIPAA? And the short answer from the government side is yes, it's a breach, right? So I think that the answer really is a little more nuanced than that. The question is, it has to go through a breach analysis. It is a security incident, right? And then the question is it actually a breach? And there's the multi-factor analysis that you go through, right? So it's a security incident because it's an interference with systems operations, right? So if it is a security incident, then you go down the road and figure out if it's a breach. I mean, a breach is usually thought of as the sort of acquisition or use or disclosure of PHI. So the question is whether the ransomware, which encrypts data, generally speaking, is that an acquisition of the data by the attacker? Generally speaking, these attackers aren't looking to acquire the data. So I have a slight bone to pick with OCR on the question of, is this a breach? But under their rules, and they get to write the rules, it's a breach, right? So it would need to be reported if you go through the multi-factor analysis and determine that a security incident involving ransomware meets the definition of breach. The other thing is that it is even if it's not a breach, it's an issue because it makes that data unavailable, right? So
Right.
it, it it's sort of a semantic issue here. Even if it's not quote unquote a breach, it is a violation of HIPAA because HIPAA requires that you maintain the availability of this data. And if it's encrypted by a ransomware attacker, it's no longer available. So you violated the regulation.
Got it. Uh, the CE that has an effective compliance program and is the target of a ransomware attack, do you recommend the payment be made to the hackers, or would this be contingent on your backup systems, or I guess even if the level of encryption of the data?
So I think contingency planning is super critical. And if you've done your contingency planning right, you can get away with not paying the ransom and restoring from backups, right? You may lose a day's worth of information, but in most cases, I would say don't pay the ransom. I'm not giving specific advice on this webinar, on this show, but my gut tells me don't pay the ransom. There have certainly been cases, whether in the situation of ransomware attacks on healthcare providers or otherwise, where ransom is paid and the data is not released, right? Then what do you do?
Right, right. I mean, that's the thing about ransom is once you pay it, doesn't mean that they're not going to try to extort more.
Right. Or they just ignore you. They walk away with whatever bitcoins you've just sent them.
Right,
Um,
right.
the other thing to remember, and this has come to the fore as some healthcare organizations have experienced these kinds of attacks, is you can have a terrific contingency plan, but you must have that contingency plan printed out and on a shelf and with all of the forms that you need to use in a binder on the shelf, not online, not stored in the cloud somewhere, not on your computer.
Right.
Because when the ransomware hits, you're not going to be able to access that stuff digitally, right? So just I saw a case where a hospital had all of its stuff online, available to no one in the event that when they actually needed it. And one staff member had actually printed stuff out and kept it in a binder. And that's what saved that hospital in that instance.
Wow. Right, right. And there are of course software programs out there to help. I mean, obviously encryption and backup software. So not sure if this was asked previously. If a patient emails a doctor from their, oh, we're kind of getting into the email land here. If a patient emails a doctor from their unsecured Yahoo email and discusses their health information, can the doctor reply directly and still be compliant, or does the exchange of messages that contain PHI have to be done via a secure patient portal or some other secured means of communication?
So again, my approach to this is that it is up to the patient, and that's consistent with the regulations. And there should be an explicit consent by the patient, even though the regulations would admit of the possibility that simply by sending the email from a Yahoo account constitutes consent by the patient to have an answer sent back to the Yahoo account, which is insecure. Again, I would just prefer to have a statement that actually says, I recognize that this is insecure, but I want to use this anyway because I just want to get an answer.
Right, right. In the case of a ransomware or any potential breach-related security incident, shouldn't law enforcement be engaged as soon as possible after the initial assessment? Do you call the cops?
Yes, I think that that would be worthwhile.
Mm-hmm.
But again, I would my MO here would be to be super prepared so that you don't need to actually hope that you get access to the encrypted data, but that you have a workable backup.
So it's right there. We're starting to get some questions also related to blockchain, which was the last topic we briefly touched upon. I think that that last answer, the Yahoo email answer you
Yes.
gave, is that answer true for 2017 or 2018?
I don't see a difference.
There's no difference, right? Okay, you're right. So several people have asked, like, what's the definition of blockchain? You know, obviously this is a new term that's sort of going around. I recommend that if you Google blockchain in healthcare, there are actually a number of good articles out there that talk about the impact blockchain may have on interoperability and on data security. That's what I had to do because it took several people having to use various analogies for me to understand at a very minimum what blockchain actually was. But we will be talking about this in April. On April 10th, David, believe it, we've got just 2 minutes left, so I want to obviously mention and plug our upcoming cybersecurity panel discussion. Obviously, we got ransomware questions today on April 10th at 2 p.m. David is going to be moderating that. We have a panelist from the HIM Cybersecurity Task Force, and we have a panelist from the WEDI.org Cybersecurity Task Force, and I think it's going to be a great conversation, and we'll be talking about ransomware and cybersecurity, obviously, on this conversation.
Great. I look forward to that. I hope
Yeah.
you can all join us for that as well.
Yeah, I'll make sure everybody gets the registration link when I send out the recording of today's event. David, we are all out of time. I want to thank you for Hipaa Chat. I will see you on the cybersecurity event in April, and I believe we have another Hipaa Chat coming up in May. So for those of you in attendance, look to your email box for information about both of those events. David, thanks so much for your time. It was great seeing you at HIMSS.
Absolutely. And
Yeah.
looking forward to a spring full of compliance.
Absolutely. We'll talk to you later.